Greetings and salutations. We'll give a couple of minutes for everybody to join in. Hello, everyone. My name is Ruthie Solani, and I'm the chair of the IGCS Education Committee. I'd like to welcome you to the first IGCS COVID-19 Project ECHO. Before we get started, I'd like to take a minute to thank you all for being here. During such an unprecedented time, we know there are many demands for your time, and we trust you will find tremendous value in today's session. As information regarding the pandemic is continually evolving and the care of our patients is rapidly changing, our goal is to bring together the global community so we can discuss gynecologic oncology cases with special consideration to COVID-19. If we could advance the next slide. A few housekeeping notes on ECHO format and etiquette. We will have a case presentation followed by a didactic and close with a 20-minute Q&A segment. Panelists will be the only ones able to speak during the presentation, and attendee microphones will be muted. We have collected questions through the registration process, and additional questions may be submitted today during today's presentation through the Q&A feature at the bottom of your screen. We will do our best to address as many questions as possible. If you encounter any technical issues, you can connect with the IGCS staff via the chat feature. Today's session will be recorded and shared on the IGCS website within 48 hours. I'd like to start with a brief overview of the COVID-19 situation. As mentioned today, this is a session outline, and the recording will be up on the website. As you all know, the coronavirus, or SARS COVID-19 2019, is a single-stranded RNA virus. It predominantly affects the lungs, the upper and lower respiratory tracts by binding to the angiotensin-converting enzyme site in the epithelium. Common symptoms include fever, cough, shortness of breath, myalgia, but there are also GI symptoms such as diarrhea and nausea and vomiting. I can have the next slide. We know that transmission is predominantly due to respiratory droplets and close personal contact. However, we have to be aware that touching a surface and then contact with our oral mucosal surfaces can also transmit the virus. And this is important, particularly when considering surgery in patients who are COVID-19 positive. Bodily fluid has also demonstrated the detection of the COVID-19 virus. However, the transmission is not clear. It has been detected in respiratory tract specimens as well as blood and stool specimens. Of note, in pregnant patients who are COVID-19 positive, it has not been detected in breast milk and/or amniotic fluid, but the transmission risk is still unknown. Viral shedding is highest earlier in the course and can occur in patients 24 to 48 hours prior to symptoms. It continues for up to 2 weeks, for 7 to 12 days in mild and moderate cases and greater than 2 weeks in severe cases. Even after recovery, PCR positive test can result up to 4 weeks later, but it's unknown if this is related to an infectious condition. Just a review of the timeline, the first case was identified in December 8th in Wuhan, China, and as you can see from this timeline, it rapidly escalated. On March 11th, the pandemic was declared by the WHO, and on April 2nd, over 1 million cases were confirmed. This number is continuing to escalate at a very rapid rate. This is just a general geographic distribution, and as you can see, this affects everyone worldwide, and we are excited to have many members from across the world here today, and we hope that your interactions help enhance the content of today's program. Before we get started with the case, I just want to review some associated factors in mortality, because this really impacts our gynecologic cancer patients. We know that the older patients are at higher risk for severe cases of COVID-19, and if we can advance the slide. We also know that comorbidities, particularly cancer, it has a higher rate of severe cases or even deaths from this condition. And if we can advance the slide again and again. The impact on cancer patients has also been evaluated, although this data is still emerging. We know that patients who are either cancer survivors or active patients with cancer, that they have a higher rate of need for invasive ventilation, ICU admission, or death. And you can see from the survival curve here that patients without cancer have much improved recovery than patients with cancer. Next slide. I have the pleasure of introducing our esteemed panelist, Jihyun Liu, from a professor and director in the Department of Gynecologic Oncology at Sun Yat-sen University in Guangzhou, China, is joining us. We also have, Dr. Daniela Rivero, OBGYN consultant from Campus Biomedica Hospital in Rome, Italy, and Renee Perheza, professor of gynecologic oncology from Instituto Nacional de Cancerologia and Clínica de Oncologia Histórica in Colombia. I also have the pleasure of introducing our case presenter, Dr. Wendell Nauman, professor and director of research in gynecologic oncology and associate medical director of clinical trials at the Levine Cancer Institute in Charlotte, North Carolina. And our didactic lecture will be presented by Emma Rossi, assistant professor of OBGYN at the University of North Carolina at Chapel Hill in the United States. Emma will be speaking on our March 24th publication, How Long Is It to Safely Delay Gynecologic Cancer Surgery? Without further delay, I will turn it over to Dr. Nauman for a case presentation.
Thanks, Ruth. So please note that this case consultations do not create or otherwise establish a provider-patient relationship between any IGCS volunteer, clinician, and any patient whose case is being presented. Responsibility for the patient remains with the medical team who cares for the patient at the presenting institution. So we have for our case presentation a 71-year-old woman who is postmenopausal and has had about 1 month of pelvic pain. Her past medical history includes type 2 diabetes, chronic hypertension, hyperlipidemia, and hypothyroidism. Her family history is relatively unremarkable. The CT scan shows a complex 9-centimeter right adnexal mass with omental nodularity and small volume ascites, which is not amenable to ultrasound drainage. Abnormal labs include an elevated CA-125 at 579 and a slightly elevated CEA at 8. Physical exam, patient is obese with a BMI of 42. She is somewhat limited in her mobility with an ECOG score of 2. And on physical exam, the only finding is a 9-centimeter, slightly tender right adnexal mass. CT scan is shown. The mass looks highly suspicious for malignancy. So the plan of treatment was, because the patient was somewhat frail and we were a little bit worried about the ability for her to tolerate surgery, we were going to get a biopsy of the omentum to confirm the diagnosis. And we had planned to treat her with 3 cycles of neoadjuvant chemotherapy, followed by surgery, possibly minimally invasive, after 3 cycles. This was scheduled, but CT scan called and informed us that we could not do a biopsy as the case was considered non-essential due to the COVID-19 epidemic. I called the radiology department and they still refused to do the biopsy because they were so busy. We were informed that all surgeries that are not immediately life-threatening are on hold due to increased surge in our hospital. And I could not get a endoscopy scheduled for the same reason, to evaluate her elevated CEA. So our options at this point were to give chemotherapy without pathologic confirmation, or to wait until she was symptomatic. So over the next 2 weeks, the symptoms got worse with increasing abdominal pain. Her CA-125 increased to 1,253. After discussion, the patient opted for chemotherapy without a biopsy, but now the infusion unit is closed due to the need for additional hospital bed space. So I think this highlights the rapidly changing situation that we have in many places. I think the situation is different for everybody, but we have to remember that this doubles every 3 to 5 days, depending on where you are. And so short-term plans will change rapidly. And I just wanted to discuss this in terms of deviations from standard of care and see what our panelists had to say about this.
We can open it up to the panel to make a couple of comments on situations that they've experienced regarding delay of care, particularly diagnostics. Daniela, being in Italy, I'd like to start with you.
Yeah, and it's a very interesting case that could occur in each of our hospitals. So I agree with the choice to postpone the big surgery in this moment in patients with ovarian cancer in advanced stage, like this case with mental involvement with peritoneal carcinomatosis in favor of neoadjuvant chemotherapy and later surgery. In fact, in this particular moment, when we're planning a treatment for our patients, it's mandatory to consider multiple factors, such as comorbidities, age, immunostatus, because first of all, we should to prevent that patients becoming infected, but also we should preserve the hospital resources for COVID-19 patients. For example, the intensive care unit beds or ventilators or blood products. So the risk to start a treatment without a specific diagnosis could lead to an incorrect diagnosis. Thinking about, for example, a Krugenberg tumor or breast metastasis or specific histotype like the low grade, that as we know, the low grade can respond very well to the chemotherapy. So in Italy, for example, we try to centralize oncological patients to the referral center. So it's very difficult that a patient can have a surgical biopsy by laparoscopy or by CT scan. But I have a question for Wendell, is possible. And do you think that a possibility, Wendell, it could have a cytology, for example, from ascites by ultrasound to have more information?
Yes, certainly that would be my choice if she had fluid that was amenable to biopsy. But yeah. I do, and I have been fooled before in this situation by cytology where the, as you pointed out, the cancer might be a low grade, and that's difficult to call on the cytology diagnosis. Yeah.
Okay.
And I know you experienced this in Italy in terms of just closing down all care. Is this a situation that you run into?
Yeah. Yeah. Yes, it's the same.
And June, from China, you probably have experience also. Do you have any comments?
Yeah, I just do agree to give this patient maybe the neoadjuvant chemotherapy first, but it's hard to get the biopsy, get the pathology results. This is a big question, so I agree with Dr. Rovro's comments, and we need some identification of diagnosis. So at this time, maybe we can more often to use some non-invasive methods to make a more clear diagnosis. Sometimes, such as for this lady, maybe we can test HE4, another tumor mark. If HE4 increased, obviously, maybe just indicate there's a malignancy, and also high-grade malignancies. I think there's another way. Also, I think could we just give the patients neoadjuvant chemotherapy first cycle if she is had a good response to the chemo? Maybe to help us to make the right diagnosis.
Thank you. So what we're going to do next is a couple of poll questions. If we can move to the next slide. So we clearly know that there's lots of delays, and we just want to see how it's assessing you. So the first question is, are you anticipating significant delays in surgery, radiation, imaging, or chemotherapy as a result of the pandemic compared to your normal schedule? And you can just click on whichever time frame you're experiencing. And then the second question, which we need to scroll down for, how have these changes impacted cancer care? And it essentially ranges from no changes to care to currently cannot deliver cancer care, as you heard in this case. And while you're voting, I'd like to ask Dr. Pareja if he has any comments on these questions that we just posed to the group before we get to the didactic. Renee, any comments?
According to the presented case, the only option now for this lady is surgery. And even during COVID-19 pandemic, you will have to perform some surgeries. So you need to be assured that this patient is not a COVID patient right now by asking for a rapid test, CAT scan, and then take her to the OR, taking all the preventive measures, PPE for all the equipment, because we will have to operate some patients, and this patient is getting worse. She's right now in pain. So you need to operate some patients under special circumstances.
Thank you. And I'd like to introduce Dr. Emma Rossi, who's going to present delays in gynecologic cancer surgery.
Thank you very much, Ritu. In advance, I have no conflicts of interest to declare. So why are we talking about delays in surgery in this era? Well, obviously, we want to preserve personal protective equipment. We want to keep our patients out of the hospital, and ideally as many staff as possible out of the hospital, or alternatively resourced elsewhere during this pandemic. And we want to preserve other resources like inpatient beds, ICU beds, and ventilators, keep our patients out of the emergency room from a postoperative complication readmission, for example. And in order to facilitate this, most healthcare systems are implementing some kind of restrictions on elective surgeries. And elective is deemed as no harm will occur if the surgery is not performed. But then there are clearly surgeries where harm will be incurred if it's not performed, but there's a time window in which it's safe. And we often, healthcare systems will refer to these as priority type cases. And cancer cases are often included in that. And so depending upon where your health system is in relation to this anticipated or experienced surge in COVID patients, there may be anywhere from a restriction on all surgeries, as we heard in the case presented, to sort of a gray zone where priority type cases are allowed. And how they define that is if, once again, if harm will occur if the surgery is not performed within a certain time period. But the decision making about whether that harm will occur is left up to us, the surgeons, to determine. So what are some of the harms that potentially could occur? We'll advance the slide, there we go. So from the patient perspective, there's certainly some concern, some fear and anxiety regarding, will the cancer spread? Will it progress? Will it become worse? Something that might have been curable now will be incurable. And many of our patients don't know their diagnosis before surgery, or certainly they may not know their stage and therefore prognosis and future therapies. And us as surgeons are also concerned that potentially something that right now is operable might become inoperable if we wait. We're worried about not advocating for our patients and their needs, which may be different from other patients. And there's some personal concerns regarding medical legal issues, some concerns regarding our livelihoods being put on hold. And then something that's a little, that's something that I could say I'm experiencing, which is somewhat of a feeling of impotency when you're canceling cases and stopping doing work during a time when our colleagues are actually ramping up what they're doing. So these are perceptions of potential harms. But what's the reality? Well, there is a little bit of data to look at this. In endometrial cancer is a really nice paper that was published a few years ago by Dr. Shalowitz. This is an American study, so looking at a US population where delays in surgery are usually driven by a confounding variable, such as patient comorbidities or some other systematic issue which is likely to confound and portend a worse prognosis from cancer. What Dr. Shalowitz's group did is they separated out endometrial cancer cases in the National Cancer Database, which is a large nationwide database capturing about 70% of cancer surgeries. And they separated out low-risk cancers, so grade 1 and grade 2 cancers, from high-risk cancers, grade 3 and non-endometrioid cell type. And that's relevant because that's kind of how we think about these cancers when we're determining priority. What they looked at was the survival for every week of delay from the time of diagnosis. And what they determined was that, first of all, there was not upstaging of cancer. So cancers for whom there was a delay in surgery were not more likely to be advanced cancers than cancers who had their surgery performed earlier. And for the low-grade cancers, they observed a safe period of waiting of about 8 weeks. And if you look on the slide, you'll see the bottom two figures, the bottom two graphs are the adjusted measures, and adjusted for various confounders that might portend a worse prognosis, like stage, race and ethnicity, insurance status, comorbidities, etc. And so the figure on the bottom left is the low risk cancers. And for about 8 weeks, there's a period, it appears a period of safe waiting before mortality goes up with waiting. Interestingly, for the high-risk cancers, that safe period of waiting appears much longer, meaning that delays in surgery do not appear to impact survival for several months, actually more than 4 months, 18 weeks before they saw that mortality was higher. Why might this be the case? Well, when we think about low-risk and low-grade cancers, these are cancers that are commonly able to be cured by surgery. And so anything that's going to delay that potential curative therapy or impact that curative therapy being delivered is probably going to have a greater relative impact on those patients' outcomes compared to a high-risk cancer where there's multiple other non-surgical factors that are impacting how they will or will not survive their cancer. And so while this may be a little counterintuitive, what I learned from this data is that when we're triaging our cancer cases, either in the outset or in the aftermath of this pandemic, we probably shouldn't prioritize high-risk endometrial cancers in the timing ahead of low-risk cancers. This data was also supported by a systematic review in endometrial cancer cases that was published earlier this year. So in this systematic review, they looked at multiple studies evaluating outcomes with delay in endometrial cancer surgery, predominantly US centers, but also a couple of Canadian center trials. And what they found, they concluded, was this 8-week period seemed to be a safe period for waiting, after which they did notice some worse outcomes. What about with ovarian cancer? This is more relevant to our case. Well, is it safe to wait? Well, with ovarian cancer, we clearly have a medical alternative to surgery, and that's neoadjuvant chemotherapy. But in normal times, there's a nuanced decision-making regarding when we implement neoadjuvant chemotherapy versus primary cytoreductive surgery. These are not normal times, though, and so we're having to change our thought processes a little bit about who we do and don't think are candidates for one or the other. For some, it's an algorithmic approach. So if your health system's allowing you to do some surgeries other than emergent surgeries, then some clinicians are looking for factors that portend a longer hospital stay, or maybe an admission to a nursing home, which is a very high risk activity right now, or an excessive likelihood of admission to ICU. And if a patient has factors that would predict that might be their outcome, then there's a much more liberal application of neoadjuvant chemotherapy. And then the other alternative option is neoadjuvant chemotherapy for all apparent advanced ovarian, fallopian tube, primary peritoneal cancer. Well, is that safe? Is it safe to give medical therapy or start with medical therapy for all advanced ovarian cancers? Well, there's now 3 randomized control trials that have have measured the outcomes of neoadjuvant chemotherapy versus primary cytoreductive surgery in advanced ovarian cancer. I've listed the data here from the Lancet Oncology publication, which pooled the results of 2 of those large trials. And what the conclusion of these 3 trials is that neoadjuvant chemotherapy is non-inferior with respect to overall survival and progression-free survival for these advanced diseases. Now, clearly there's some small font there in the publications. There's some subgroups who do better with one treatment modality versus the other. And so once again, in normal times, we typically have, rather than an all or none approach, a more nuanced approach to selecting cases. But what this data tells us in these abnormal times, it is probably perfectly safe to offer our patients with apparent advanced ovarian cancer primary neoadjuvant chemotherapy. What about early stage disease? This is a little trickier. So the patient who has a complex appearing, worrisome appearing adnexal mass on imaging and elevated tumor markers, is it safe to delay her surgery? Well, in the UKC TOCS trial, which was a trial evaluating whether there was benefit to ovarian cancer screening, in the multimodal screening group who underwent ultrasounds and CA-125 assessments, those who screened positive with abnormalities in those tests did not go straight to surgery. In fact, there was a mandated 6 to 12-week wait period before repeat imaging and labs, and then only then, if the abnormalities still persisted, did they go to surgery. And yet in that trial, there was still a significant downshift in stage, meaning in the screened population, there were more stage 1 and stage 2 cancers observed. And so the interpretation of this data, the extrapolation of this, is that it appears that that 6 to 12-week wait period after identification of an abnormal mass or tumor marker elevations does not appear or does appear to be safe in still being able to capture early stage cancers. For cervical cancer, we have some built-in observations of when we have to delay surgery. We sometimes observe cervical cancer diagnosed in pregnancy. And when that's the case, it's frequently accompanied by a delay in definitive therapy, including radical hysterectomy. And so how do those patients do? Well, fairly consistently in all the observed series, and clearly they're all retrospective series, but a fairly consistent finding is that the survival from their cancer is the same when cervical cancer is identified in pregnancy compared to matched controls who have their cancer identified outside of pregnancy. Even when the delays can be as long as, on average, in this data that you can see on the slide, as average as 20-week average delay from time of diagnosis before definitive therapy. And so I think extrapolating from the cervical cancer in pregnancy literature, we could feel somewhat reassured with delaying radical hysterectomy for the 4 to 6 to 8 week period that we may be faced with during the COVID crisis. Similarly, for patients who have had a prior excisional procedure, LEAP or cone, we know that there's data that supports the safety in waiting for 6 weeks or so to allow for decreased morbidity at the time of radical hysterectomy. And that's also additional data that for small microinvasive lesions, it's probably safe to wait that short period of time. In this paper, which was looking at a Canadian series, lower genital tract cancers, including cervical and vulva cancer, what they observed was that among patients who waited more than 28 days for their surgery, there was no significant progression in disease observed compared to those who had their surgery less than 28 days from time of diagnosis. Now, they did observe some patients who progressed between diagnosis and surgery, and they were all in the group who waited more than 28 days. But the mean length of delay for those patients was actually 75 days, so substantially longer than what's likely the time frame of waiting that we'll be facing during this time. So the summary of all of this data, for me, speaks to the conclusion that it's likely safe to delay surgery for most of our gynecologic cancers for up to 6 weeks and potentially longer. Obviously, this does not apply to emergent conditions, hemorrhage, obstruction, in some cases for molar pregnancy or GTN where surgery is indicated, that might also fit into an emergent indication. Another important thing to consider is when are the delays going to start? And so there's certainly usually about a 4-week period through which most health systems will experience a severe surge. And during that time, there may be a moratorium on all surgeries other than than emergent. And so therefore, if there's some allowance for you to do cancer surgeries before that moratorium on all but emergent surgeries, you might want to factor that into your calculations of wait time. There's going to be an enforced wait time of probably at least 4 weeks. And so for many of us, we're continuing to perform cancer surgeries on a case-by-case basis leading up to that, so that we don't exceed our wait time beyond that 6 to 8 week period. Thanks for your attention.
Thank you, Emma. And I'd like to open it up for questions and answers to the panelists. I'd like to thank the attendees for submitting questions. And we also have some pre-registration questions that I think are interesting and overlap with some of the questions that were submitted during this session. So I'd like to just start by asking the panelists if they have any comments. There were some questions that came in or comments that came in. Oh, I'm sorry, let me actually go back to the poll. So the poll that we asked earlier, these are the results that we see here, where you can see that it looks like most people are having to wait about 2 to 4 weeks or having a delay of 2 to 4 weeks prior to being able to do diagnostic or therapeutic interventions. And some people aren't affected yet, which is actually incredible. And then how has this impacted care? It looks like there's been a significant impact to care for a majority of people and how they treated patients. And I think that's what most of us are experiencing. That's almost 50% of the attendees. So thank you for submitting your responses to that. But one of the comments that's been kind of a theme throughout the questions coming today is it truly ethical to delay this care? A patient may be deemed early and then they end up with an advanced stage at final pathology. How do we rectify this? How do we discuss this issue with our patients? So I'd like to open this up to the entire panel. I'll start with Dr. Naumann.
Well, I mean, we're going to do the best we can for as long as we can. I mean, this is almost a wartime triage in many areas of the world that we may not have the luxury of providing standard of care to patients, and that was really the point. I mean, we're going to have to be nimble, and some of the questions have come in about, what do you do? What do you do if you don't have surgery? What do you do if you don't have diagnostic procedures? I just heard there's one question about prioritizing chemotherapy in terms of who gets chemo, and you're going to have to decide who is the most important patient to operate on. So for me, as was brought up by one of the attendees, was, we prioritize our high-grade endometrials more than anything because there's no other effective treatment. We can't give them neoadjuvant chemotherapy. We don't have, radiation's probably not the best option for them. So how do you do that? And who do you prioritize chemotherapy for? I mean, if you have very limited resources, you're going to give it to the patients curative first and then down the road.
Yeah, Daniela, do you have any comments?
Oh, yes, I think it is feasible. I think the best choice is the surgery for that patient in which surgery could be led up a benefit. So I think it's not possible worldwide for the COVID-19 pandemic. So in that patient with advanced stage, and in that patient we know the patient is not pseudoreductive, it's important to perform the neoadjuvant chemotherapy and later the surgery. So for example, in other cases, for example, the endometrial cancer in the stage 1, we can perform, for example, a hormonal therapy. So for example, for stage 1A, we perform the hormonal therapies, or for all dysplastic lesion in cervix. For example, we can postpone the surgery later. So I think, but 6 weeks, I think, is the time, no more, to postpone the surgery.
Yeah, I think the comment about it being a kind of wartime mentality is right. We have to preserve resources, because even with surgery, you're not just using ventilators, but you're using blood products, you're using hospital resources, nursing.
Well, not only that though, if you operate on this lady, it means that you are not going to operate on a high-grade endometrial. So you're going to have to choose. I mean, for each person, you're going to have to choose who is the most important to operate on there, and that's what we're doing. So when we reshuffle our patients, we have limited resources, we go down the priority list. This is rational.
And I will share some resources. I will share some resources at the end that are available that comment on, when it's safe to prove safe to delay, just like you mentioned, Daniela, about the dysplasias and maybe the low-grade endometrial cancer. We have a pathologist who's part of this webinar who actually made a comment about the importance of histology, which I think we all agree with. There was also a question submitted. I'd like to pose it to Dr. Liu. Should we avoid frozen sections at this time if we are operating on a patient?
So I think it's great to have temporal categories to just triage the patients to have a different management. So like just for gynecological cancers, I would prefer to manage the patients according to the clinical stage and the different types of cancer. As for example, for early stage ovarian cancer and endometrial cancer, we can use, we just should put these patients as prior prioritization to undergo surgery, but not for early stage cervical cancer, because cervical cancer just progress slowly, especially for the stage 1A and the stage 1B1. But however, for those patients with advanced and recurrent disease, I think the chemotherapy maybe is a best way for the alternative treatment. Also, the radiotherapy is an alternative option for the cervical cancer and the endometrial cancer. Also, for the endometrial cancer, just like Daniela mentioned, we can use hormone therapy to treat them for the delay of surgery. So just I think that for the different types of cancer, for the different clinical stage, we should use a different strategy to manage them. Also, I think for those very like this lady, can we try to use a PARP inhibitors, because that's an oral medication? Can we use that to treat this maybe that's a late advanced ovarian cancer patient, something like that?
Yeah, that's a great segue. There were a lot of comments on using oral alkylating agents that have come through. If the patient's BRCA positive, is it better to use a PARP inhibitor either sooner or even, prior to chemotherapy to avoid immunosuppression and visits? What are the panel's thoughts on that? I'll start with you, Emma.
Yeah, I think it's intriguing. I think during periods of high community levels of COVID-19, when you're very worried about the patient leaving their protected home, I think it's valid. Clearly, we're functioning outside in a data-free zone when it comes to utilizing those agents, but it's almost a little bit of a preoperative window study being enforced here in practice to see how patients respond to these agents prior to a definitive management. And I think if it was a high baseline prevalence concern about bringing my patient into a high risk setting, then that might be an option that I consider. But it certainly wouldn't be my first option.
Renee, do you have any thoughts on that?
Yes, one thing which is important to consider is what moment of the pandemic are you facing, the hospital or the country. If you are in the first part of the curve, you can operate your patients and take advantage of the availability of operating rooms, anesthetics, etc. When you reach the peak of the pandemic, definitively you will not have resources. And I think it's the moment to start delaying some treatments. But I think this is tricky and depends on the hospital, on the country, on the resources. All of those things have to be considered. Another issue is in some regions of Italy, they declare COVID-free hospitals in order to avoid contamination with COVID cases. And those hospitals used to handle cancer cases. And the general medicine and the general consultations are managed in another hospitals. So it is important to try to reserve a free COVID environment in order to keeping administering oncological treatments.
No, that's a great point. And several people have asked on the questions that have come in is what is the standard or what is your institution doing for pre-operative COVID testing? At our institution, we are not regularly doing it. We're screening patients, but we're not universally testing for surgical patients. Does anybody else have a different or separate experience?
Are you testing patients if they show symptoms or have been exposed before surgery?
We are. I assume that's probably general practice if the testing is available. But we are not universally screening. I've heard some places mention that they are doing universal screening prior to surgery.
In developing countries, it's very difficult to do universal testing for all the patients. So we have designed some questionnaires about symptoms, about contact with positive cases, and we need to proceed according to the patient's status. But every patient without testing should be considered as possible case, and the PP measurements should be taken in the OR for all those patients.
I know that in China, where they've had a little bit more experience, and potentially June can speak to this, the anesthesiology staff will often institute protocols of screening with temperature of all patients, and a temperature greater than 97.3 will trigger further workup. So they'll use a temperature. Now, we obviously observe vital signs before all surgery in all patients, but we usually don't have hard metrics on when to postpone a surgery based on temperature. But using temperature is sort of one sort of fairly low-tech, inexpensive way to help trigger or triage which patients preoperatively you might use that definitive COVID test that's hard to come by.
So actually now in China, we test the people's temperature everywhere. But in our hospital, I work in a cancer hospital and in Guangzhou in south of China. So in our area, so the COVID is not so serious. And we're almost now back to the normal normal status for the operation and for the chemotherapy to give the patients. But we test the patient. If the patient are hospitalized, admitted to the hospital, she need to be tested, give the thoracic CT scan to see that if there is any changes in the both lungs. And also she needs to test the temperature, and also needs to test the RNA test. And so if the virus test is negative, so she can be allowed to get admitted in the hospital. So this is in our area, but it's said in the Wuhan city, you know, that's most severe area in this time. So it's still very in a very serious restriction. They need maybe 2 or 3 times of viral test if all the tests are the negative, so the patients can get into the hospital. But the doctors there told me, so many patients with gynecological malignancies are still in the delay of the surgery and the chemotherapy as well. Maybe start from the April 8th. So many normal, I think more and more the surgeries and the chemotherapies are allowed to start, but I think that will be the gradually to be back to the normal.
Thank you. There was an interesting question that came up, and there may not be a definitive answer, but one person had asked, what are the potential sequelae that COVID patients, positive patients, or patients who had infection who've recovered may affect with future cancer care? So what are the things that you think we may need to look out for? I'll pose this to Daniela first.
Yeah. As they said, the most problem in the future will be the delays for patients with COVID-19 infection, because needs to remove, for example, from research trials and all of these things could lead to tumor progression and to have, unfortunately, a poorer outcomes. So I'm in contact with many patients associations worldwide for the advocacy program. And one of the most important things is that sometimes, unfortunately, we forget the psychological aspects in our patients during this important period, during this pandemic. So women, our patients have fear, are depressed, and have uncertainty about the future because about the possibility to have a cancer progression, as Emma said in her presentation before. So all these aspects can influence the future compliance and the patient-doctor relationship, in my opinion. So we need to talk with our patients by phone, by telemedicine, and need to stay connected with them and keep attention to their needs. So in this way, we continue to have a best standard of care for our patient, minimizing the risk of infection. We should encourage in our routine the telemedicine, for example. So for follow-up visit, for evaluating the toxicity, for example, in the research trial, I think.
Emma, do you have any thoughts? Oh, go ahead, Renee, I'm sorry.
Yeah, I think it's important during this pandemic to discuss all the cases into a multidisciplinary DISPO conference, because there is a shared responsibility among all the members of the therapeutic team. So you should include radiotherapists, medical oncologists, surgical oncologists, and also the patient and the patient willings, because we need to work together trying to provide the best care during these challenging times for all of us.
Yeah, Dr. Rossi, any thoughts?
Yeah, I mean, I think if the question is how do we reinitiate therapy for the former COVID patient who also has a cancer diagnosis, I think one thing that we're still trying to figure out here is how do we know when she has cleared her virus and is now safe to sort of initiate immunosuppressive therapy or to come into the office itself and be around other cancer patients. For most people, they'll use sort of standards of 3 negative tests. They'll test about a week apart. And so we're potentially looking at additional delays in receiving cancer care at that point in time. But I think looking for at least 3 negative tests is probably a valid measure. And then there's these very deconditioning illness. So during that time that she is recovering from a viral illness, I think it's important that we are reaching out to her throughout telemedicine, what other resources we have to ensure that she is rehabilitating and getting strong, getting good nutrition, so that she can then embark on her cancer therapy when she's recovered from her virus.
I wonder if even years from now, months from now, when the pandemic is hopefully contained and ideally over, if we're going to have issues with ventilation in some of our patients who were COVID positive, even if it's a year later, and are we going to have issues administering certain therapies like that, for instance, which may have higher lung toxicity? Are there other sequelae that we'll see? So I think it's really important, like Renee mentioned, that we work together. And our goal is, as we continue these echoes, that we have our colleagues from pathology and radiation oncology and radiology as part of this to help us understand, because I think we're just at the beginning of our understanding of how it's going to impact us long term. I think we're struggling in the short term, but I think there's still a lot of long term issues that we'll uncover. There have been several questions about cervical cancer that I think are interesting, and some of the questions are regarding locally advanced cervical cancer. And I'll pose this to you first, Dr. Pregna, is should we do, higher doses and less frequent treatments for these patients, or should we, for brachytherapy, should we do 9 gray in 2 fractions as opposed to 7 gray in 4 fractions? What are your thoughts on kind of hyperfractionation of radiation therapy? Renee?
We were discussing about hyperfractioning with our Department of Radiotherapy, and they are willing to start to do it with some selected patients. But the evidence about safety of hyperfractionations is not as solid to offer to all the patients or to take a decision right now. So it is something to consider, but depends, again, on the institution and on the resources.
And there's been several questions about surgery versus radiation therapy for early stage cancers. And my 2 cents is, radiation is going to be more visits to the hospital. So if these patients can safely undergo surgery, you have the resource available, but that would be, a one-time visit with a short recovery versus radiation where it's more frequent. Do the panelists have any comments on that?
I think it's important to consider in low resource settings, because if the patient has to go to the hospital 20 times for 20 sessions, is 40 use of public transportations, because it's not common to have a private vehicle in Latin America. So 40 expositions to metro, to buses. So we should consider if is worldwide to provide these, to administer radiotherapy to those patients with early stages. Another issue is, I have no doubt about postmenopausal patients, but I have several doubts for premenopausal patients to offer her radiotherapy.
And then we've also had a lot of questions about the safety of minimally invasive surgery. So Wendell, I'll pose this to you. Can you comment on the safety of laparoscopy or robotic surgery in this setting?
Yeah, and I noticed these questions, and some have commented that they don't do any minimally invasive surgery. I think there's certainly some risk to the OR personnel, and as was pointed out, the screen for symptoms, many of these patients who have the virus are asymptomatic. There is certainly potential for aerosolization with laparoscopy, and there's a joint statement out that we probably shouldn't do laparoscopy on patients who were known or suspected to be COVID-19 positive. But right now, our practice is to do the laparoscopic surgery in the patients who are not known to be positive. We are lucky enough to have N95s in the OR for all personnel on the right now that we reuse. And so we try to get them out of the hospital. Nobody gets admitted. So we do outpatient laparoscopic surgery for these patients and send them home. We don't see them. We see them only in the OR, and then they go straight home from the PACU.
So, I want to caution against some of the fear that's present regarding minimally invasive surgery in the setting of the coronavirus. A lot of it is largely, in fact, all of it is speculation. There's been no reported cases of transmission of COVID in the OR through transmission via aerosolization or smoke plume, for example. Smoke plume is created with many laparotomy surgeries as well when we use electrosurgery in open cases. So it's not singular to the laparoscopic experience. And I think it's really important to understand that minimally invasive surgery, as Dr. Naumann pointed out, is associated with less use of vital hospital resources, particularly hospitalization, blood products, and the potential for an ICU admission or a readmission to hospital. And so in the absence of any data that supports that this is a feasible route of transmission, and keep in mind, even with other viruses, there's not being documented transmission by a smoke plume for other viruses, even those that are bloodborne. So in this setting, I think we should be careful about overreaching statements of bans against minimally invasive surgery, for example, even in COVID positive patients. I think if you're operating on a COVID positive patient, clearly that's when I mean, we should ideally have practice universal precautions on all patients, but knowing that PPE is limited in many settings, certainly in patients with documented COVID-19, having personnel minimize time in the OR around the time of intubation, because that is the time when transmission is the highest. So have only the necessary personnel in the room during intubation, and have other personnel fully dressed in full PPE with appropriate donning and doffing procedures. I think is probably, but not excluding minimally invasive surgery, which will get that patient out of the hospital back into the community faster.
Yeah, and to Dr. Rossi's point, we really need some documentation if the peritoneal cavity is even contaminated with this virus. We don't know that. If somebody has a protocol to test patients, that would be very helpful information to us, and particularly if you can quantify it.
And if I can, just a brief comment about this, because recently Italian and Chinese team published on Annals of Surgery a paper about the risk of minimal invasive surgery versus the conventional open approach during COVID-19. So some recommendations in this paper to reduce, for example, the escape of gases, because in general, as we know, previous researches have shown that in general, laparoscopy and electrical equipment can lead to aerosolization, as Emma said, for example, for hepatitis B, HPV, HIV. So probably due to pneumoperitoneum. So some recommendation could be use the specific safe devices during laparoscopy, filters or suction devices, and keep the pneumoperitoneum pressure on the lowest possible, and to reduce the Trendelenburg position time. And I think that due to the lack of data, ideally we should consider laparoscopy for selected cases, where clinical benefit to the patient exceed the risk of potential infections. So ideally, the best thing could be to test each surgical patient. In Italy, we start to test each surgical patient since 2 days. So I think yes, ideally is the best.
Thank you. We're coming to the top of the hour, and I know that this will be an ongoing discussion. Kathy, if you could pull up my slide. I just want to share some resources with you that are available. And once again, these will be available on the website. I'm not going to go through them, but there are some comments here on recommendations. This is our website here that links to the COVID-19 specific resources. And this will be on the slides available for you. The next slide is a publication by the International Journal of Gynecologic Cancer, which Dr. Pregna was part of. And it just talks about some guidelines or considerations for outpatient clinic visits and management of disease, which I just summarized here. And obviously, clinical decision-making is going to have to go into this. Similarly, the next slide is SGO's guidelines, cited gynecologic oncology, which also provided some guidelines on high-risk patients, general considerations, and management of disease. And then the last slide is a joint, this is a modified elective surgery acuity scale, so which patients really should be prioritized for surgery. Remember, this is going to be based on the resources that are available at your site, your personal COVID-19 experience and surge, and then also your clinical judgment. And then the next slide is guidelines on minimally invasive surgery. And I think this is constantly a moving target, so don't be surprised if things that are seen here are updated in the next few months, weeks, as we get more experience. I think taking every precaution to protect provider, staff, patients is a critical need. I think that's my last slide, and I'd just like to thank all the and I'm sorry, this is the WHO Operational Planning Guidelines. This was just published last week, and it just provides some guidelines. And I think it's just a reminder that we're learning how fragile our healthcare systems actually are. You know, there was a comment about developing countries. I think we're experiencing this in developed countries. So I think this is a lesson learned, and hopefully we'll be better prepared day by day in the future. I'd like to thank the panelists for their participation and time. I'd like to thank all the attendees for their comments, and I'm sorry we didn't get to all of them. They were excellent questions, but we do hope that this is an ongoing process. We will be providing a post-survey questionnaire, and we ask that you put other topics that you're interested in hearing related to COVID-19. And then also, if you're interested in participating, we welcome people. We would love our members to be a part of this, so please let us know if you're interested or have specific topics that you would like to discuss. In our closing, I'll leave it to the panel if they want to leave the group with one last thought or tip or some positive motivation. And I'll start with, before I turn it over to the panelists, I'd also like to thank the IGCS staff. It was amazing, and this in such a short time frame. So I'd really like to give them accolades for what they put together and continue to put together. So I'll start with you, Renee. Any comments for the attendees?
Yes, please stay safe. Try to give the better care you have to your patients, and don't forget that we are doctors and we are in the front line on the treatment of patients with COVID. So we need to take care of us rather to take care of the others.
June?
Yes, so we should keep ourselves stay in safe. I think our hospital staff also should protective for their own safe. There's also that's good for the patients. So I just recommend the patients and doctors to more often use telemedicine. So in our hospital, we have a iCloud hospital app. So we just talk to our patients in the iCloud hospital more oftenly, so we can give the patients advice. So just keep well.
You're muted. But anyway, I would say do push the hospitals. We had early on, the hospital was trying to conserve PPE, and you know, the physicians and the nurses and the people in the hospital are the most important resource we have. And so push your hospital to do things that will protect your staff. I will say that at least the initial reports in surgery are actually fairly good, in that the risk of transmission is low in the OR because everybody's got a mask on, and there was an early report, I believe it was out of China, where they had 41 people exposed with just normal masking in surgery to somebody who turned out to be COVID positive, and nobody got infected from that exposure. So that's certainly encouraging.
Our world is facing a devastating crisis to this new virus. So we are physicians, it's true. But first of all, each of us is a person. So please, you don't forget to talk with your patients and stay connected with them. And it's really important to continue to share our experience by webinar, by teleconference, to improve the approach to care. Everything is gonna be all right, friends.
Sorry, I got disconnected for a moment, but I'd like to close and thank everybody once again, and we'll look forward to the next COVID-19 echo.
Thank you.
Bye. Thank you very much.
Thank you.